Hi everyone, today we are going to start USMLE practice pulse questions that are related to general pharmacology that we already studied in our previous live classes. And today, our first question is a 34-year-old kidney transplant patient pretty with cyclosporine come to office due to nausea and anorexia. The patient underwent transplantation 6 months ago and had been doing well until recently. On examination, his blood pressure is 160/96. There is no tenderness at the site of transplanted kidney. Serum creatinine is 3.4, and the serum cyclosporine level is marked increased. A month ago, he had a normal blood pressure and normal level of cyclosporine and serum creatinine. Further questioning revealed that the patient had been drinking increased amount of grapefruit juice lately as part of attempt to improve his overall health. Which of the following mechanism is most likely responsible for this patient's chronic condition? Guys, if you mean the diagnosis, this patient having a new onset hypertension, an elevated level of serum creatinine and cyclosporine, and is all a suggestive of acute calcineurin inhibitor, nephrotoxicity. Calcineurin inhibitors such as cyclosporine cause dose-dependent brain vasoconstriction and tubular cell damage, which can precipitate acute renal failure due to rich endocrine to the high value of serum creatinine. And secondly, cyclosporine is extensively metabolized by the liver in gastrointestinal tract via the cytochrome P450 enzyme systems. And it is specifically one enzyme that is a CYP3A isoenzymes. Inhibition of intentional P450 enzyme by the phycomycins present in grapefruit juice can slow the breakdown of drug metabolized by this pathway, rising the circulating level of affected drugs. Medication with narrow therapeutic index like cyclosporine have the highest risk of toxicity, and the main reason is the cyclosporine is metabolizing by the liver with the helpful cytochrome P450 enzyme, but with that drug, the patient is taking a cytochrome P450 inhibitor, that is grapefruit juice. If you guys know about that, you already learned. I already told you in inhibitors or drug metabolism chapter, the grapefruit is the inhibitor of cytochrome P450. So the right answer is inhibition of cytochrome P450 enzyme in the good form that is responsible for the older condition, the new onset of hypertension, elevated levels, serum creatinine, and cyclosporine. Now we have moving to our next question. Our next question is, a group of investigators in performing an experiment designed to assess genetic variability in drug biotransformation. A fixed dose of isoniazid is given to a group of volunteers, and the plasma drug concentration is measured 4 hours following administration of the drug. The foreign distribution of plasma drug concentration in the subjects is obtained. Radiation of which of following process provides a best explanation for the shaded area of the core. In this question, we have to tell about. In this graph, the shaded area is due to which of following mechanism: degmethylation, gluconidation, hydrolyzation, acetylation, or amine oxidation. First, we have to know about the name of the drug. The name of drug is the isoniazid. If you guys know from the drug metabolism chapter, the isoniazid is metabolized in the liver in the phase 2 with one reaction, that is acetylation. So the right answer is acetylation. Isoniazid is metabolized by acetylation. The speed with which a patient is able to acetylize drugs depends on whether they are genetically fast and slow. And we also said fast and slow acetylators. The presence of phosphorus low acetylated within the same population results in bimodular distribution of the speed of isoniazid metabolism. Slow acetylators on it increase risk of adverse side effects, and this graph is a bimodular distribution. 1 and 2 is a bimodular distribution. Okay? Next question is a 57-year-old man with real pyelonephritis admitted to hospital. His past medical history is significant for diabetes, hypertension, and 2 episodes of transient ischemic attacks. His CM-creatine level is 3.2. Therefore, he needs to be starting on an antibiotic that depends mainly on non-renal clearance, which the following characteristic should be the antibiotic also have if hepatic metabolism and clearance is desired. If you guys recall the chapter of volume distribution on about the excretion, we have to think which is the quality the drug will have if we needed non-renal clearance. For that, the kidney, you have to know the kidney is the primary site of excretion of most drugs. With or without pure chemical modification, the liver. The liver is the major site of drug biotransformation and metabolism, but some drugs are also predominantly eliminated by the liver into the bile and feces. Drugs with a high intrinsic hepatic clearance tend to have a high lipophilicity and a high volume of distribution. If you guys want the drug will excrete from the liver, then it should be high lipophilic and having high volume of distribution, and this highly lipophilic drug tend to purely eliminated in the kidney as these agents separately cross the tubular cell membranes after filtration to re-enter the tissues. So, the high lipophilicity or high solubility of the lipid allow the drug to cross the several barriers more easily and the hepatocyte. It can then be excreted in the bile through adenomatous of elimination. In addition, high lipid solubility assures the wide distribution of many different tissues, including brain, liver, and adipose tissues. So the main characteristic the antibiotic should have is the high lipophilicity. The high lipophilicity permit the drug to enter in hepatocytes and go to the metabolism and excrete it to the bile or feces. Okay? If you found any patient having some kidney issue, having the pyelonephritis, or having any type of issue regarding the kidney, so we will recommend the non-renal clearance drug to him. And this drug should be highly lipophilic. Our next question. A 64-year-old man evaluated for persistent fever and weakness. He had a history of aortic valve replacement for aortic stenosis. Physical examination reveals a new cardiac murmur with scattered petechia and subprinted hemorrhages seen on his extremities. Echocardiogram shows a vegetation involved in one of the aortic valve leaflets, and the blood culture grow enterocyte. As part of the patient's treatment, 240 mg of intravenous gentamicin is started. The pharmacy calculates that this patient gentamicin had a volume distribution of 30 liters, half-life of 4 hours, and the demonstrate first order and one compartment kinetics, which following the most likely serum drug concentration touch before the next dose 8 hours later, with having the 4 hours of half-life. And he's saying which the one with most likely same drug concentration before the next dose 8 hours later. It's the first half-life, second half-life, and you have 2. Give the concentration after the second half-life, okay? And you're having 240 mg, it's a distribution 30 liter. So first we will count the plasma concentration. The 214 divided by 30, it will become 313 and 3 of them. 24. Okay? 3 it's 24. So our concentration is 8 mg per liter. After the first half-life, it will become 4 mg. After second half-life, it will become 2 mg. Top like that, and answer is 2 mg per liter. Because in the first order, there is a constant fraction of drug eliminated. So, in first half-life, 50% eliminated. In second answer, 50% eliminated. So, 8, 4, and a 2. And after the 2 half-lives, the concentration of drug will be 2 mg per liter. Okay? A new antibiotic developed for the treatment of infections caused by the resistant gram-positive cocci at the volume of distribution of 11 liter. It is eliminating refers order kinetics and the half-life of 10 hours. If given by the continuous infusion, approximately how much time would be required for the drug to achieve 95% plasma steady-state concentration? If you guys recall the half-life chapter, the topic of a half-life is studied about this steady-state on where the rate of elimination is equal to rate of administration. And if the one line that steady-state is mostly achieved on 4 to 5 half-lives. So 1 half-life is equal to 10 hours. So after the 4 half-lives equal to 1 half-life equal to 10 hours. So 4 half-lives equal to 40 hours. So most probably the steady-state, to achieve a 95% plasma steady-state concentration, we have to wait for 40 hours. Our next question. A large multinational drug corporation conducts a phase 1 clinical trial to evaluate the safety profile and pharmacokinetic properties of new drug designed to treat refractory epilepsies. Nature studies in animals showed that the drug undergoes extensive metabolism by the liver into gluconization byproducts that are primarily excreted by the kidneys. The curve below demonstrates the gluconidation rate of the drug over a wide range of doses, which form is the most accurate about the drug metabolism. If you guys concentrate on this graph, this is a drug dose and this is a gluconide metabolism rate. Okay? First you focus. It is that exact proportion, exact constant fraction of a drug is metabolizing. Understand? So, in the exact constant fraction of a drug is metabolizing and eliminating is a first order reaction. But after some time, the concentration of drug that is metabolizing, it becomes a constant number or a volume. Constant concentration is metabolizing. If you guys focus on that point, a constant fraction, for example, 50%, okay? The 50% is metabolizing. But after this point, the drug is metabolizing by a constant concentration, a specific concentration, like only 2 mgs metabolizing. Only 2 mgs metabolizing. So, if you guys recall about the kinetics, first order kinetic and zero order kinetics, the metabolism of this drug, it just started with the first order kinetics because of a constant number of friction. The constant friction is eliminating the metabolizing. After that, the constant proportion, a constant amount of the drug is just metabolizing. So it is zero order kinetics. For us, first order, then it will be kinetic to zero order. It's having a same proportion, like 50%, and it is same amount. Then 0 then. So here it's one statement. If you guys focus, the metabolism begins to switch to 0 the kinetics near the point 2. If you guys focus, this is a point 2, and from here, the metabolizing is switched to 0 the kinetic. And it is the right answer. The next question is, researchers developed a novel glycopeptide antibiotic similar to vancomycin that is a bactericidal against many gram-positive bacteria. From animal studies, they determined that the effective drug dosage is 5 mg per kg per day, administered intravenously in divided doses. In a clinical trial, the antibiotic is administered to adult and neonatal patients with gram-positive infections. The drug is found to be effective in adults but not in neonates. During further analysis, plasma concentration of drugs are measured in both groups, with the results shown in the image below. Compared to the adults, which of the following neonate affected is the most likely cause of difference in drug effectiveness? If you guys focus on the graph, on y-axis you having the plasma concentration, on x-axis we having the time. And with the time, the plasma concentration is higher in adults and lower in neonates. Let's find the answers. Decreased cytochrome P4 activity, decreased linear blood flow, elevated plasma protein level, or high body water content. Okay guys, the neonates have higher proportional body water compared to adults. Neonates having the higher proportional body water compared to adults. This can result in lower plasma concentration of water-soluble drugs. So, it results in lower plasma concentration of water-soluble drugs. And if they are administered at the same weight-based doses are given to adult patients, like I was certainly compared to either which of the following are the effective most likely cause of difference in drug effectiveness: high body water content. High body water content. And due to that reason, the lower plasma concentration of water-soluble drugs. Called units having the high proportional body water compared to others. Therefore, the plasma concentration of drug is less. Like for example, I am taking 2 grams and distributing 2%, okay? And if I am taking 2 grams and distributing it to 5%, then the part of this drug given to each is high, like 1 gram and 1 gram. But to them, it's very less. Like it will be only 2. You have to divide the 5 pieces of stew, and then you have to keep to the children's. Okay, like 0.40 gram, 0.40 gram, 0.40 gram. Seem like that. Neonates having the higher body water, like high proportion of body water, and adults having less. To the volume and distribution is next to plasma concentration is higher in adults, but in neonates, the water is a higher, so concentration will be decreased. So it will be a very high-yield point that the water-soluble drug having the lower plasma concentration if administered in the neonates due to high proportion of body water compared to adults. And we have to move to the next question. A 17-year-old girl comes to the office due to worsening acne. The patient's acne had been well controlled with the oral doxycycline therapy. However, over the past month, the acne has worsened on her face and back. The patient was recently diagnosed with iron deficiency anemia due to abnormal uterine bleeding and began taking a combined oral contraceptive and iron supplements. Physical examination shows comedons in the pustules on her face and upper back. The remainder of examination shows no abnormalities. Preterite forming is most likely a cause of this patient worsening symptoms due to adverse effect of hormone therapy, bacteria resistant to antibiotics. On this led decreased absorption of antibiotic, it is the increased clearance of antibiotic, increased protein binding, antibiotic. Actually, this woman is taking the iron supplementations. Okay? She's taking antibiotics, iron supplementations, and this young patient with the acne had a good initial response to tetracycline therapy. However, after the initiation of new medication, she experienced a significant loss of effectiveness just to a possible drug-drug interaction, and that interaction is chelation drug interaction. In this interaction, the formation of insoluble compound with a polyvalent and cation indicates for intense interact form, and it decreases the absorption of drug. Like effuses and taking antibiotic and iron subruin the iron metallions. Iron is a chelation cations that will re-interact and make a insoluble compound with the antibiotics, and it will decrease the absorption of that drug. And it's a commonly involved are tetracycline, fluoroquinolones, and levothyroxine. These antibiotics mostly interact with some metallions like iron, calcium, magnesium, and aluminium. So, due to this reason, there will be a decreased absorption of antibiotic, due to which she did not getting a desired effect of antibiotics, in which antibiotic she is saying like doxycycline therapy. She is not get as much good effect of tetracyclines. Okay? The next question I asked you on 2-year-old woman. It brought to the office one new patient evaluation. She recently moved in with her daughter. The patient reports frequent dizziness but can't provide additional details regarding her symptoms. Medical history includes moderate dementia, hypertension, tonsils, ischemic attack, depression, chronic insomnia. Blood pressure is 120/72 and the pulse is 66 per minute and regular. Urological examination shows disorientation to time and the place. But normal deep tendon reflexes, no focus and motor deficient. The patient medication scheduled into 12 different drugs that are used to manage her chronic condition. Which form of medication should be discontinued at this time? First, we have to check the age. The age is 82 years old. So for these type for older ages, we mostly use one criteria called the Beer criteria. Beer's criteria. According to these criteria, the Beer criteria identify drugs that should be used with caution in geriatric patients. The common drugs to avoid are anticholinergic drugs. Anticholinergic drugs like first-generation antihistamine, centre-reacting alpha-2 agonists, tricyclic antidepressant, benzodiazepine, and other-sedating medication, antipsychotics, amantine, antiarrhythmic like digoxin and scaltamazarelixin. These all drugs we avoided in elder or older patients having a way too high age. And due to these patients, and these all the patients are at a increased risk of adverse effect of medication due to decreased drug clearance. You guys know with the increasing of age, the drug clearance also decreases, and due to our data, high risk of adverse effect, cognitive and sensory deficient, multiple comorbidities, drug and drug interactions, and poor drug compliance. And this is called the polypharmacy. If you are prescribing more than 5 drugs to one patient, it's called polypharmacy, and it's an over-counted medication. Particularly, it's a concern in elderly and can lead to a prescribing cascade in which the additional drugs are given for adverse effect that are misinterpreted as a new medical condition. And according to BIA criteria, we are not giving first-generation antihistamine, gastrointestinal antispasmodics. So in that drugs, if you take amlodipine, aspirin, diphenhydramine, donepezil, hydrochloride, and cysteine, this is one drug that's in frustration had antihistamine that is diphenhydramine, generation antihistamine. And this drug we should avoid in all the patients, okay? And this, which criteria? It is a BIA's criterion that we are avoiding first-generation antihistamine, gastrointestinal antispasmodics, alpha-1 blockers, centrally acting alpha-2 agonists, antiarrhythmics, tricyclic antidepressant, antipsychotics, barbiturates, along with acting sulfonylureas, scaltamine, and one more, like that. So, but I'll even move to my next question. And our next question is, a 16-year-old go home. If you guys take this question, then it's so lengthy and having long statement. So why we can go with our technique, as I already told you before, for the keyword questions. You guys can go with different technique, read the last statement of the question, because all the questions are time-based. For saving your time, you have to write the last statement and then second last. And 80% of questions we will get our main point in these last statements. So first, let's try and that we should find with the most likely underlying mechanism of drug toxicity in this patient. In this patient, if we check the videos, the 2-tryptophan 1.3, ethane phosphatase 120, and this high value 3096. And for the alanine aminotransferase 4000, that is. But now we have to evaluate which of the following is mechanism for drug toxicity to this patient in the liver. And these are question that because of progressive including nausea, vomiting, she had initially seen in the emergency department 24 hours ago for nausea and vomiting. But for dischargement hand examination laboratory study was unremarkable. After this, we did the patient revealed, I am so upset, my boyfriend broke up with me and I have been taking a lot of pain medications to relieve my pain. Okay guys, now we will getting the point. Like this patient taking painkillers because she broke up with her boyfriend, so making attempt of suicide. So already you guys know for the painkiller, for pain discretion who took a large quantity of the pain medication initially had nausea and vomiting, and has done 12 secular actualized site upper abdominal, quadrant pain, and marked elevated aminotransferase. These findings are consistent with the overdose of which medicine? Acetylaminosine. Acetylaminosine are commonly used on analgesic, and when you're taking it in the appropriate dose, acetylaminosine produces small amounts of the toxic metabolite called N-acetyl P-benzoquinine, amine. If you want to write initial for you can write NAPK. To keep it is a toxic metabolite of acetaminophen, which is conjugated with the glutathione in the liver and it's excreted. As to for therapeutic dosage, glutathione becomes saturated, allowing excessive amount of NAFK to form ADEX and read hepatic proteins that disrupt hepatocyte mitochondrial function and cause oxidative entry. And so due to this, the right answer is the drug metabolite is not drug-induced, not reactive condition. Drug metabolite induced the mitochondrial dysfunction. And this NAFK attack with mitochondria are often hepatocyzed and make it dysfunction. So right answer, drug metabolite induce mitochondrial dysfunction. Please don't take overdose of acetaminophen. It will make dysfunction of your liver by making dysfunction of your mitochondria of hepatocytes. Our next question is, a 68-year-old man come to the office due to worsening back pain. The patient has a swell history of lumbar degenerative disc disease. It limits his daily activities. He declined the surgery and the treatment with known pharmacological interventions and known opioid analgesic have not adequately controlled the pain. The patient began taking long-acting oxycodone 5 months ago with a good pain control. Over the past 2 months, he reports progressive worsening of the pain despite a modest increase in dose. The patient also takes acetaminophen for breakthrough pain and osmotic laxative for the constipations. Physical examination shows lower bad spinous tenderness, but no lower extremity neurological deficiency. Spine imaging shows no significant changes. The ritual funnel disease for decreased analgesic efficacy suspicion. Actually, it's a patient taking the oxycodone is opioid from the last 5 months and probably he having the tolerance. In this tolerance, he having the options of pharmacodynamic tolerance and pharmacokinetic tolerance. First, we have to make the difference between pharmacokinetic and dynamic. If gradually add me the absorption, distribution, metabolism, and excretion, the plasma level of active drug it decreased due to impaired absorption, increase in tissue distribution like plasma protein binding and adiposity, increased metabolism due to P450 enzymes inductions, or increase in excretion. That will be pharmacokinetic tolerance. If there is abnormal absorption, distribution, metabolism, or excretion, then it will be pharmacokinetic tolerance. But in that all scenario, there is not any type of abnormal absorption, distribution, metabolism, and excretion. So, the both options are eliminated. But in the pharmacodynamic tolerance, the plasma level of active drug is unchanged, the normal pharmacokinetics. However, the action of a drug on target cell is blunted, like receptor downregulation. For in simple words, the pharmacodynamic tolerance means the receptor downregulation, and it decreases the intracellular signaling, and this reduces the overall pharmacological effects. In both cases, the tolerance can be innate or acquired, but in this case, a chronic opioid therapy leads to the development of acquired pharmacodynamic tolerance via the downregulation and decreased responsiveness of the opioid receptor system. So this patient is taking oxycodone from the 5 last months, and due to which there is a downregulation of receptors, and due to downregulation of receptors, they will be decrease in intracellular signaling and the decrease in response of the drug. So right answer is B, pharmacodynamic tolerance to decrease responsivity of opioid receptor system. Okay guys, again I'm saying the difference between the pharmacokinetic tolerance and pharmacodynamic tolerance. Pharmacokinetic tolerance is related to absorption, distribution, metabolism, excretion abnormalities due to any drug, then it will be pharmacokinetic tolerance. If it is a pharmacodynamic tolerance, then it will be due to receptor downregulation and intracellular signaling abnormalities. Now we move to our next question. A 55-year-old woman is diagnosed with metastatic breast cancer. The patient is treated with opioid analgesic for backbone bone pain. Let it well controlled during the first week of therapy. The following week, analgesic dose become ineffective. The patient reporting nausea, itching, and constipation. She has become very weak and is unable to walk due to pain. the opioid dose is increased, the patient is concerned about side effects with a higher dosage. Nothing that her son had a history of opioid dependence. I've watched him suffer a lot of bad reactions. The physician explained the concept of tolerance to opioid and that high doses are commonly required to control pain. Over the next few weeks, a patient would likely experience the following. Dice in this opioid analgesics. For the pain, that person taking opioid analgesic, the most common side effect of opioid is a contribution. This is the high yield point. Made them at this point is tested, so don't forget the main and most common side effect of opioid is a constipation. So right answer is worsening the constipation. Next question is a 55-year-old woman. Is it already? We are done with that MCQ, so we have to move on. Next question. That is about a woman but having the age of 52-year-old. So first we have to write and read last, which is the following antibiotic for the patient most likely given to treat that cellulitis. Okay. After the taking antibiotics, she having the bilateral hyperreflexia and cutronus, and she began to have the seizures. Okay. Now, this is a clinical scenario about cellulitis, having swelling, pain, erythema, and right lower extremity swelling. The patient medical history includes diabetes mellitus and depression, and medication includes metformin, paroxetine, and multivitamin. Already she is taking metformin and paroxetine and multivitamins due to previous illness like diabetes mellitus and depression. But now she is taking some antivitamin for the cellulitis. Now she is continued on her home medications. 3 days later, the patient become to reach with a severe abdominal cramps and diarrhea, an elevated temperature of 39.2 and a blood pressure 180/100 and heart rate 120 per minute on examination. The patient diaphoretic and tremulous and her pupils are dilated. So now we have a question. Actually, this question about a drug interaction also. So guys, it's a very important topic. Drug modification, drug interaction. So now we have to tell which of following antibiotic the patient is using. Firstly, this is a case of serotonin syndrome. And this syndrome is characterized by the triad of autonomic instability that includes hypothermia, hypotonia, hypertension, and tachycardia. And this is the first stage of the autonomic instability. The second is altered mental status. And third is neuromuscular hyperactivity like laser seizures, hypoactivity. So, as let's get into the system and differs, it is due to an increased serotogenic effect in the central nervous system, to increasing 5-HT1A and 5-HT2A receptor stimulation, and this is mostly happen due to interaction of the doses between the serotonergic drug used at therapeutic doses, and it's most commonly due to combined effects of several serotogenic medication overdose and drug-drug interaction. The serotonin effect is increased in the monoamine oxidase inhibitors. Monoamine oxidase inhibitor combined with serotonergic antidepressant. Guys, the serotonin syndrome is happening when? Again, I'm writing monoamine oxidase inhibitor. You are taking with serotonergic cheap. Antidepressant. Accused taking a drug for the depression also and ansuriano, even antibiotic to it. So that's one drug that is lines of weight that is used to treat the infection that is caused by the positive bacteria, particularly vancomycin-resistant Enterococcus and methicillin resistance. And these are called mid-main use of SSRI on with the other serotonergic medication, like under the antibiotic like clindamycin, doxycycline, penicillin, and vancomycin, they don't having any effect on monoamine oxidase inhibitor. Okay, so they don't cause the serotonin syndrome and combine with serotonergic antidepressants. This is serotonergic antidepressant, and lanzolide is an antibiotic that gives a monoamine oxidase inhibitor effect other than this antibiotic. So the right answer is that lanzolide that is causing the serotonin syndrome by doing the interaction with serotonergic antidepressant drug. The next question is 47. Your main comes to the office to the worsening muscle weakness and a dark urine for the past 7 days. 2 weeks ago, the patient was evaluated for dyspepsia and found to have a helicobacter pylon infection. He was started in the treatment, had partial symptom lymphoma and medical history in hypertension, hyperlipidemia, which he take amlodipine and simvastatin. Temperature in 37.1, blood pressure 130/80, and pulse 74 per minute. Physical examination showed diffuse muscle tenderness, laboratory irregular reviews, elevated blood urea nitrogen, and the serum creatinine level. Unimicroscopic should now red predicted by Dustin, which a form of medication most likely precipitated his patient conditions. Anyway, guys, they are history of hyperlipidemia. A patient has history of hyperlipidemia, and he's using statin drugs. So kindly think about statin myopathy. Because statin myopathy can be happen due to drug interactions, and this patient having the muscle tenderness and weakness, and a dark urine that suggests some myoglobinuria due to myocyte necrosis. In the context of ongoing statin therapy for the hyperlipidemia, this presentation likely represents statin myopathy. The statin myopathy is due likely least in part to decrease the myocyte production of coenzyme Q10. Serum muscle breakdown markers like creatinine kinase are often elevated, and severe cases may lead to rhabdomyolysis with subsequent acute kidney injury like elevated MUN and creatinine. So, these statin myopathies happen due to cytochrome P450 inhibitors, due to OATP inhibitors like organic NN-transport proteins or additive myocyte toxicities. But in that medication we are having one inhibitor that is cytochrome P450 inhibitor, that one is erythromycin. Erythromycin that inhibit the cytochrome P450 due to the decrease in metabolism of drug, and it requires statin myopathy in the body. Okay? That I'm again saying the inhibitors and the inducers are so important. Please go through it from again and recall it again and again and remember that as much you can. Okay? The next question, a clinical trial is being conducted to evaluate the safety and efficacy of a novel therapy to treat hepatic Cohen disease. The medication is monoclonal antibody against alpha-4 beta-7 integrin, which inhibits the migration of T lymphocytes into intense unit parenchyma and produce a good selective anti-inflammatory effect. Patients who have active moderate to severe Cohen disease and have failed conventional therapy are enrolled in the study. Many of these patients have the renal and hepatic dysfunctions, and some take other medication that affect cytochrome P450 enzyme, which the following is the most appropriate dose adjustment in this patient population to decrease the drug's toxicity. Guys, in this the patient using monoclonal antibodies. And these are used to treat growing variety of malignant leukemia, lymphoma, or melanoma, and autoimmune disease like Crohn's disease, rheumatoid arthritis. The therapeutic effect of monoclonal antibodies is achieved by binding to their target antigens in the plasma or on the cell surface and blocking deleterious receptor instructions or triggering a cytotoxic immune response against abnormal cells. Because of their larger molecular size, they can't be administered orally and must be given via intravenous or subcutaneous or intramuscular routes. Unlike most other drugs, monoclonal antibodies are not eliminated by the hepatic and renal glands, but they are removed by the target-mediated drug clearance or non-specific clearance. So these drugs are given IV, IM, or subcutaneous, and these drugs are not excreted by liver and kidney. So they did not having any concern with cytochrome P415 times. So high doses, lower doses, anything inducers, inhibitor, nothing can affect the monoclonal antibodies because these drugs are excreted by other methods like target-mediated drug clearance or non-specific clearance by binding deficit receptors and macrophages. So the right answer is no dose adjustment is necessary. Because if you are taking any inhibitor of cytochrome P450, inducer of cytochrome P450, it has no effect on the excretion of monoclonal antibodies. So we did not need any adjustment for its doses for getting the desired effect. Thank you. So next question is healthy volunteers are enrolled in the phase 1 clinical trial investigating the properties of unusual oral antimicrobial agents. The drug is administered in different amounts to the volunteers over the course of several weeks to determine the best doses that minimize the toxicity by maintaining true levels above the minimum inhibitory concentration. While reviewing the data, the researchers note that drug half-life seems to vary among such study participants. An increase in which of the following pharmacological parameters is most likely responsible for the longer life seen in certain individuals. That if you guys remember the formula for half-life, a half-life is equal to 0.7 multiplied with the volume of distribution and divided by area clearance. If the volume distribution is increasing, the half-life will also increase. If the clearance will be decreased, half-life will be increase. Okay? So they are asking increase in which of the following pharmacological parameter is responsible for the longer half-life. So increase in volume or distribution will increase the half-life. According to formula, the half-life is equal to 0.7 multiplied with the volume or distribution and divided by clearance. So increase in volume or distribution will increase the half-life of dead certain drugs. Okay? The next question is a 58-year-old man with a type 2 diabetes mellitus come to the emergency department with fever and malaise, during discomfort and left flank pain. The patient had a history of diabetic autonomic neuropathy with bladder dysfunction and have been hospitalized for the multiple times for the recurrent urinary tract infection. His temperature high, blood pressure 94/50, pulse 180, and height is 180, and weighted that and BMI 46 on mg. An oral examination, these are suprapubic and left costal vertebrate anchor tenderness. After review of culture insensitivity test from his PON hospitalization, the patient is started on an empiric antibiotic regimen that includes aminoglycosides. While calculating the appropriate dosage, a hospital pharmacy using an adjusted body weight that is lower than the patient actual body weight, which is the following best explain the use of these adjusted parameters. Right? In this scenario, the drugs are typically used to maintain the plasma drug concentration within the target range. An ultra-fixed drug dose isn't convenient for the providers, and the patient dosing based on body weight is often used to improve the safety and efficacy, particularly for the medication with a narrow therapeutic window like the Japanese aminoglycosides and anesthetics. Body weight affect both the rate of drug clearance, volume, and distribution. The drug clearance quantity proceeds with the lean body weight, the weight of all non-adipose tissue, including the muscle, liver, and kidneys. Likewise, the volume distribution for most drugs also gets larger as lean body mass is increasing. However, obesity causes a disproportionate increase in adipose mass. And you guys know having a BMI of 46 kg. But it is clear and having a disproportionate increase in adipose mass, which can have a variable effect on the volume or distribution depending on the solubility of drug, like it is hydrophilic or hydrophobic. The aminoglycosides are large charged molecules that can't cross cell membranes. Their volume distribution limited to the accessory space, which is increased only marginally in obese individuals. Either result those thinking of obese spacing it based on adjusted body weight that takes into account only proportion, approximately 40% of excess adipose tissue. So distribution of drug is limited to the extracellular fluid compartment. Because aminoglycosides having a large charged molecule that can't cross cell membranes. Why it is extracellular fluid? Because if you recall the volume distribution chapter, again, the large molecules and charged molecules having the limitation of extracellular fluid compartment only. The right answer is A. Distribution of the drug is limited to the extracellular fluid compartment. Our next question is, after the 1-year-old man come to the office due to persistent renal condition and rhinorrhea, the patient had a history of allergic rhinitis and recently moved across the country to start a new job. His nasal symptoms worsened after the move, and he started using an over-the-counter alternative decongestion. If you guys remember, just in this lecture about in the drug modification, I already gave that examples to you guys about an intranasal decongestion supply that initially provided prompt relief, however, after a few days. He had to increase the frequency and the number of supply per nostril needed for adequate symptom control. On examination, the nasal turbinates Australia went appealed with a clear nasal discharge, which the following mechanism most likely responsible for the patient increased medication use. In this question, we have to tell the reason why this patient increasing the medication day by day. If you guys remember, it's one topic that could take you for like in drug modification, tachyphylaxis, in drug modification in which we already talk about the internalization of receptors. Like you are losing one blocker for the nose, internal streets here, there's some receptors. You are blocking these receptors. After some time, there will be more receptors. It'll be there, or some receptor will be hide themselves, and it known appear a holes to the blockers. And due to do internalization and we can use receptors, it will cause a tolerance to the alpha and the TT congestion that will quickly due to the receptor internalization, and both alpha and the beta-adrenergic receptor undergo conformational change on lichen binding, allowing them to activate. And this is activation of adrenergic receptor results in adrenaline binding and receptor internalization. This effect is responsible for the tolerance effect, seen with the alpha-adrenergic decongestions, vasopressors, and beta-adrenergic like bronchodilator agonists. So, our right answer is increased receptor internalizations. You guys can also check from the book. It is last topic of General Pharmacology like drug modification day that tachyphylaxis, and is an already mentioned example there, which day that internalization of T receptors. So guys, we move to our next question, that is researchers investigating the effect of heart failure on the pharmacokinetics of the anti-diabetic medication 12, a cohort experimented annually with anthracycline-induced heart failure. There's one group with the heart failure and another group with a healthy heart. Stack famine element then is administered an older dose of metformin and CM level and that monitor over time. The test repeating control animal with a normal heart function and results in shown below. Yes, some animals that are healthy animals having the normal heart. That's a failed heart. If a patient having a heart failure, then it is unable to pump. Mean he or she is unable to pump the blood to dull and like liver and kidney, then they will be decreased in clearance. So, due to that reason, after a certain time, the plasma concentration of experimental group is higher than the control group because the blood flow to the kidney or the liver decreases. So the clearance, the metabolization of that drug will also decrease. And the question in which of the following with the best explain the change in serum metformin levels in experimental element. So I already told you due to decrease in blood flow to the kidney, to the liver, the clearance will be decreased, metabolization will be decreased to dry down and decrease renal blood flow. And due to heart failure lead to reduced liver and kidney perfusion, resulting in reduced drug clearance, like metformin is excreted unchanged by the kidney. Therefore, patient with significant renal insufficiency due to heart failure or other causes like chronic kidney disease are at high risk of toxicity, and toxicity causes lactic acidosis. Okay, is the extra point. It will cause lactic acidosis again. Now on to our next question. A group of investigators is conducting a phase 1 clinical trial for newly developed synthetic opioids. After several volunteers interested, a fixed order dose, the plasma concentration of active drug, and an inactive metabolism here. The plasma concentration of a drug is determined to subtherapeutic. After the examination of same dose of a drug, the peak drug plasma concentration double the level of years after order administration, which will following best account for the observed difference in the concentration of active drug. The idea is controlled by bioavailability, and you guys know in oral there's less than 100%, but from the other routes like IV, rectal, sublingual having the bioavailability more than oral due to one reason. That is, fast path metabolism. This is the main reason the first part metabolism. So it is happening by the liver. If drug did not pass from the liver, then the first part metabolism will not happen. So if anyone is giving a drug or taking a drug, perfect or sublingual, then they will be decreased in drug delivery to the liver, and due to that, then they will decrease all not first parts metabolism. And due to that reason, there is a high number viability of the drug in body.